Hello, I'm Mary Beth Marsden, and welcome to GBMC's Ask the Oncology Expert. And today we are so happy to be joined by Dr. Farzad Masroor, who is a head and neck surgeon at GBMC. And we're talking today about the thyroid and thyroid cancer. Dr. Masroor, thank you so much for being with us.
Thanks for having me.
And I might add, good to see you again.
Yep.
So, the thyroid, we've all heard about it. We all think we know what it does, but if someone were to ask us at a party, where's your thyroid and what does it do? I'm not sure half the people there could answer it.
Yeah, so the thyroid is actually what thyroid means, I think in Greek, it means butterfly because it's a butterfly-shaped organ that is right here in your windpipe area. It has two lobes, one on the right, one on the left. It's connected in the middle, and it sits over your windpipe. So it's a butterfly-shaped organ. It sits over your windpipe, and its main job is to produce a hormone called thyroid hormone. And thyroid hormone is the hormone that really controls the metabolism in your body. So, for example, there are some conditions many of us know about where your causes your thyroid gland to be underactive or hypothyroid. And if you have too little thyroid hormone, then your metabolism is going to slow down. You're going to have weight gain, you can have skin changes, you can feel tired, you can feel cold all the time. And then the opposite is true if you have too much thyroid hormone. You'll have maybe too much energy, you'll feel hot all the time, you'll lose weight unexpectedly, even though you're not trying to lose weight. And so that's what the thyroid gland principally does. Now, there's some other nuances too. There are some other hormones that it makes, but for just the sake of a dinner party, we'll leave it at that.
So this little butterfly organ is pretty important, yet we can still live without it, right?
That's true. And the reason why we can live without it is because thanks to modern medicine, we can easily make the hormone that is missing, the thyroid hormone that is missing. And there are different kinds of hormones out there, or preparations of it. Ones that you may know of are levothyroxine, or the brand name is Synthroid. And so we know that we can give that predictably, safely to a patient in a pill form, and you can live safely without your thyroid gland.
Today we're talking mostly, I think, about thyroid cancer. And as you know, we've gotten a lot of questions from people who've either been touched by thyroid cancer in some way or are curious to know more about it, very specific questions. And a lot of those people are joining in on this conversation right now. So we want to make sure I get to all of those. And we're going to start with the most basic one, and that is, what is thyroid cancer?
Good question. So thyroid cancer is just basically cancer from the thyroid gland. So I think the better question is, what are the types of thyroid cancer? What is the range of thyroid cancer? How can it behave, and the different behavior types, and so when I think of thyroid cancer, I like to divide it into three groups. So the first is cancers that come from the thyroid lining, and specifically cancers that come from the thyroid lining that are a little bit more organized and mature, and we call that basically differentiated thyroid cancer. And that is by far the most common type of thyroid cancer. And it's an umbrella term for many types, and the most common one is papillary thyroid cancer. And then you have other types too, which are a little less common, like follicular thyroid cancer or Hürthle cell thyroid cancer. The second type, which is less common, not nearly as common as differentiated thyroid cancers, is a type of cancer called medullary thyroid cancer. And it's a different type, and it's a different category because it doesn't really come from the thyroid cells that make thyroid hormone. It comes from a different cell called the thyroid C cells. And their job is to actually make another hormone called calcitonin. And this cancer behaves a little differently than differentiated thyroid cancers, and it's a different category. The last category is luckily the most rare, and it's also probably one of the most lethal types of cancers you can have in the body. And that is called anaplastic thyroid cancer or poorly differentiated thyroid cancers. And these cancers, they do come from the thyroid lining like differentiated thyroid cancers, but they're not as organized, they're not as mature, they're far more aggressive, and they're far more bizarre looking under the microscope at least. And luckily, these are not very common cancers, the anaplastic or poorly differentiated thyroid cancers. So thyroid cancer, that's kind of the spectrum. Now, you can also have some more unusual things too, like you can have a lymphoma in the thyroid gland, which is not technically thyroid cancer, but it's a cancer that happens to be in the thyroid gland, and other things too. But I think just for the sake of clarity, we'll say those three types, differentiated, medullary, and poorly differentiated thyroid cancers.
And so for these three types of cancer in the thyroid or around the thyroid, do they all present the same way? Are we going to have possibly the same symptoms? What are the different symptoms?
Yeah, they'll present a little differently, and I think that is due to the fact that they are biologically different. So the first type we talked about, the differentiated thyroid cancers, which are thankfully the most common. These cancers are not as aggressive as the other two, and so a lot of times the way we find them these days is is basically incidentally. A imaging test like a CAT scan or MRI was done for another reason. Say the patient was in a car accident and they get a CAT scan of the head that happens to catch the thyroid gland. Or say they're in the ER and they're having chest pain and they get a CAT scan of the chest and it goes up high enough, it just happens to catch the thyroid gland. And what you would see then is a nodule, a thyroid nodule. And a nodule is just a descriptive term. It doesn't really mean anything more than that. But it just means that there's a lump or bump on the thyroid gland, and we would not otherwise necessarily know about it. And so that then leads to further testing being done, usually a biopsy at some point, and that's how a lot of thyroid cancers, differentiated thyroid cancers, are caught these days.
It's amazing to me, actually, that it would just be caught that way, and also that whoever's reading that scan knows enough to look to see what is happening in the thyroid, and they're looking at the chest or something else.
Yep. Well, I guess it speaks to the thoroughness of our radiologists. They're making sure whatever they can do, they will.
Yeah, if they've got a picture, they're going to look at everything in the picture.
Exactly.
And so you said that you would find a nodule or they'd see a nodule, but that's not something we could feel, or should we be touching around the thyroid area to see if we could feel a nodule from time to time?
No, sometimes it could be felt too, and that's another way that a lot of times I see patients is a primary care doctor is feeling the neck of an otherwise healthy patient and notices that there's a thyroid nodule there. There are stories, for example, of some patients being on TV, and viewers are noticing that there is a little bit of a bump in their neck, and they're saying, "Hey, maybe in a very kind way, pointing it out to them, maybe you should have that checked out." And so a thyroid nodule can be seen if it gets large enough. And I guess that goes to another point, is that symptoms. What are some symptoms a patient with thyroid cancer can have if if they're not in that category of an incidental finding. And so the way I like to think about it is it really comes down to location. Like where is the thyroid gland? And it's on your windpipe. It's next to your voice box. It's next to your swallowing tube, which is also known as your esophagus. And it's next to a nerve that helps to move your vocal cord called the recurrent laryngeal nerve. So if a nodule gets big enough where it pushes on those structures, you can have symptoms in one of those, related to one of the structures. So for example, if it's pushing on your swallowing tube or your esophagus, then you may have a harder time swallowing or feel like things are getting a little bit stuck in your throat. If it's pushing on your windpipe, and it can push your windpipe over to the side, or windpipe is also known as your trachea, then you may have a little bit harder time breathing. And if it's pushing on your voice box or the nerve to the vocal cord, your voice may get a little hoarse or raspy. So that is sometimes a way that thyroid cancer gets caught too. Now, the other kind, remember I told you about this really bad kind that is very rare called anaplastic or poorly differentiated thyroid cancers. That shows up very differently. So it's not subtle. If you have one of these cancers, you will notice a neck mass here. And because these tumors are so fast growing, over weeks, a patient will notice that it is growing very fast and causing symptoms very fast. And that in some ways is a true emergency. And unfortunately, it's not a very common cancer. And unfortunately, it's a very lethal cancer.
When you say it's not very common, 2% of all thyroid cancer cases, or 1%, or?
I would say about 1%, yeah.
Who is at risk or more at risk of thyroid cancer?
A lot of patients with thyroid cancer don't have any risk factors. like, you would find in other cancers of the head and neck or in the body, cancers of the mouth or the throat. A lot of times smoking is a big risk factor, or a lot of throat cancers these days we're seeing are related to HPV, the human papillomavirus. But one risk factor that is well defined is a history of radiation to your neck in childhood or your young adult life. Back in the day, from the early 1900s to maybe 1960, a lot of doctors were giving radiation to patients for benign conditions. For example, enlarged tonsils. You would see some patients get radiation for that. And then many years later, because of the radiation effect, the thyroid gland is very sensitive to it. And therefore, many years or decades later, it can develop a thyroid cancer. Other conditions that they used to do it for were like, dermatologic conditions, warts or acne. And luckily, around 1960 or so, we, as a medical community, we realized that it's not a safe thing to do, and so we stopped. And so fortunately, we don't see that much anymore. Another risk factor is a family history of thyroid cancer. So if you have a family history of thyroid cancer and you have a thyroid nodule, it greatly increases your chance of that nodule being cancer. But other than those two things, other risk factors they're not well defined. It's not like the other cancers that I talked about in the head and neck.
Is it true that young people can get thyroid cancer?
They can, absolutely, and especially young women. Women are 2.5 times more likely to get thyroid cancer, young women are, than men. A lot of medullary thyroid cancers, that second category we talked about in the beginning, are related to genetic syndromes. Like one syndrome is called a MEN syndrome, MEN, which stands for multiple endocrine neoplasia syndrome. And some of those patients can actually get a thyroid cancer in early childhood. And they have a very strong genetic disposition. So absolutely, you can get thyroid cancer at a young age.
And more women than men, is this because women are producing different types of hormones?
Presumably, it may be hormonally related. For example, thyroid nodules are also more common in women, and it has been shown that women who take oral contraceptive pills actually have a slightly lower rate of thyroid nodule formation. And your weight is also linked to thyroid nodule formation too, and your weight is also linked to your hormonal balance. So I think it is a hormonal thing, so that's true, yeah.
How is thyroid cancer different from thyroid diseases such as Hashimoto's or hyper and hypothyroidism, which I guess is Graves' disease, right?
Yeah. So the way I like to think about it is a cancer is a part of the body, wherever the cancer is, doesn't matter what kind of lung, colon, breast, those cancer cells are now, the reason why they become a disease is that they have escaped the body's control. They do not respond to the body normally, and they just want to do what they want to do. And that's how tumors form, and then they just keep growing. But Hashimoto's disease and Graves' disease and other thyroid diseases that are not cancers, it's a little bit more, it's a little different. And for example, and some of these diseases are autoimmune diseases, which means that they come about because of the body's own immune system incorrectly targeting the thyroid gland to do something that it shouldn't do. So for example, with Hashimoto's disease, which is the most common cause of underactive or hypothyroidism in the United States, what happens in that is the body produces an antibody or produces an immune response against the thyroid gland, which then causes the thyroid gland to become inflamed and not function correctly. And in fact, the thyroid gland can become enlarged and goiterous due to that inflammation. Graves' disease is an example of an autoimmune hyper or overactive thyroid condition, hyperthyroidism. And an antibody is produced by the body, which then latches onto the thyroid cell and tells it to make more thyroid hormone than your body needs. So that's kind of, in a nutshell, how thyroid cancer is different from autoimmune diseases or over or underactive diseases of the thyroid gland.
So with that said, are people who suffer from these thyroid diseases, are they at greater risk for thyroid cancer?
They are, and it possibly has to do with the immune environment of the thyroid gland. And as we know, your immune system plays a very critical role in managing cancers in your body, and that may be a reason why.
Treatment for thyroid cancer in general.
In general, so it depends on the type, but for the most common types, your differentiated thyroid cancers, which include papillary thyroid cancer, follicular thyroid cancer, and Hürthle cell thyroid cancer, and even medullary thyroid cancer, the preferred treatment is surgery. A good surgical excision of the cancer and potentially any involved lymph nodes is curative. Other types of treatments for cancers like chemotherapy or radiation are used in special circumstances. I will say that for differentiated thyroid cancer, there is a treatment called radioactive iodine, which is different than traditional radiation, which is kind of like a X-ray beam going to targeting a specific tissue. Radioactive iodine is iodine tagged with a radioactive substance, which then poisons the cell that takes it in. And since we know that thyroid cells are the cells that take up most iodine in the body, they get poisoned by the radioactive substance and then die. So, but by and large, the first line of treatment is a good surgery.
So when you say surgery, do you remove the entire thyroid always, or can you partially remove it?
You can partially remove it, under special situations. So, number one, if your thyroid cancer, your differentiated thyroid cancer, does not have any bad features to it, meaning that, and this may be a little technical, but meaning that the cancer has not gone beyond the thyroid gland. It does not have extra thyroidal extension. It's under 4 centimeters in size. It does not have other bad features like a bad type. There are some subtypes of differentiated thyroid cancers which are a little bit worse than others, and they have names like tall cell, hobnail, or insular variants of differentiated thyroid cancer. If it doesn't have these bad features and it's under 4 centimeters in size, then you can do 1/2 removal of the thyroid gland. That's called a thyroid lobectomy or hemithyroidectomy, and that is equivalent to removing the entire gland, and therefore preferred, because if you have at least half your gland left, then you can make, and a lot of times make enough thyroid hormone where you don't need to go on a thyroid hormone replacement pill.
And you know that through blood work, is that right?
That is correct.
Okay, interesting. If a patient, oh no, here's the question that we want to ask next. Is there any way we can prevent thyroid cancer that we know of?
It's a good question. And this kind of ties into our earlier question of risk factors. And I think there are not a lot of well-established risk factors that we can target to sort of prevent thyroid cancer from happening, except those 2 major things I talked about before. So if you've had a history of irradiation to your neck, then you should have your thyroid gland probably looked at more closely. Fortunately, there are not many patients like that, who have that experience. Second is if you have a genetic syndrome, like multiple endocrine neoplasia, which can put you at increased risk of medullary thyroid cancer, or other syndromes like Cowden syndrome and other rare syndromes. If you have those genetic syndromes, then maybe it's worthwhile to see a geneticist or see a thyroid specialist to see if your thyroid should be looked at more. Now, we do know, for example, with some of those patients who are at high risk of getting medullary thyroid cancer, we typically recommend removing the thyroid gland before a thyroid cancer develops, because some of those syndromes, the chance of developing thyroid cancer approaches 100%. And so it's recommended to remove the gland even before it happens. Fortunately, that's an unusual and rare circumstance.
If a patient has had previous saliva gland cancer, then had their saliva gland removed and radiation treatment, is it possible that cancer could spread to the thyroid?
This is technically possible. I would say it would be unusual. The thyroid gland can be, just like other organs of the body, can be a destination for other cancers to go to. But typically, cancers, when they spread, they spread in an orderly fashion, meaning that they would first go to the lymph nodes in the neck, and then from there to other parts in the body. And the thyroid gland as a final destination is not common, but possible.
Can cancer present in a patient who previously had subtotal thyroid resection with negative tissue results for cancer?
If a patient previously had a thyroid cancer and then it was removed with the margins being negative and there were no other adverse features, but there was some thyroid gland left behind, then that original cancer coming back on the other side, I think it would be more that the other side developed a new cancer because there's some thyroid gland left, as opposed to a return of the other thyroid cancer.
What is the chance of occurrence after parathyroid cancer after radiation therapy?
Parathyroid cancer, number one, is a different type of cancer than what we've been talking about up to this point. So, because the parathyroid glands are glands that sit on the thyroid gland, there's 4 of them, and their job is to produce a hormone called parathyroid hormone that regulates calcium. And parathyroid cancers are rare; they're not very common. And so this patient, presumably who's asking the question, their cancer had come back, and or their original cancer excision, the margins were positive, and so someone has recommended to them to get radiation therapy. Now, because it's such a rare cancer, there's not good studies on it. There's not good data on whether radiation will, or what are the chances of radiation really lowering the possibility of it coming back. There's just no good data on it. That being said, sort of clinical, opinion or sort of expert opinion would be that radiation would help. But to answer the question kind of more directly, I can't tell you a number if it's going to come back or not. But theoretically, if you've had a cancer come back, a parathyroid cancer come back, there's always a chance it can come back again.
Obviously, these questions are very specific to one specific person who's asking them and hopefully listening right now. But this one is similar in that respect. Is a patient's thyroid cancer, if rather, a patient's thyroid cancer metastasizes to the lung, is the cancer in the lung treated differently than it would had if the cancer, say, came from melanoma?
It would be treated differently. The reason why is that melanoma is biologically a very different cancer. It behaves much more aggressively. A lot of thyroid cancers, especially the kind that is differentiated thyroid cancers, and not anaplastic or medullary, but differentiated thyroid cancers, they're not as aggressive. And so for some patients, when we have thyroid cancer that's gone beyond the thyroid gland, gone beyond the neck lymph nodes, and gone to distant parts of the body, we will sometimes, number one is if that cancer has also not been responsive to radioactive iodine therapy, it continues to go despite that, or has not, responded to other treatments like potentially a surgery to remove it, or radiation to it. Then you can even just sometimes watch thyroid cancer if it's not very aggressive, and just watch it to see how it grows. If it stays stable in size and is not, then you're good. But if it continues to grow and or threaten, say, vital structures, then there are drugs that we can use that are very specific to thyroid cancers. And studies have shown that patients can have durable responses to them. Now, melanoma, when it spreads far and wide in the body to the lung and other places, it's usually does not give a good prognosis. But thyroid cancer, on the other hand, even though it's spread to the lungs, patients can still live long lives with further treatment. So it would be very different.
It sounds like when we talk about thyroid cancer specifically, there's a lot of optimism around it. It sounds like there's a lot of good treatment, and many people can live long lives without their thyroid on medications.
That's true, absolutely, except for that one rare type we talked about. But the vast majority of thyroid cancers, they behave differently. They're not as aggressive as other cancers in the body, especially the differentiated thyroid cancers. My field as a head and neck surgeon, we see a lot of cancers that are very aggressive and can threaten a patient's life in a matter of months to years. But a lot of thyroid cancer is you're right, the prognosis is much better.
With the time we have left, I would just love to talk about your perceptions and how passionate you are about the Cancer Institute at GBMC and what makes it different, what makes it stand out, you believe.
Yeah, so at our cancer center, the Sandra Malcolm Berman Cancer Center, um, I like to think of it as we basically provide university level expertise in a community level, setting, where we provide top-notch care, and at the same time, our environment is very comfortable to patients, and it's kind of like, almost like being at home. What I also enjoy about working here, and I believe strongly in, is that the leadership here is very committed, and the whole hospital culture is very committed to finding ways to do things better. And our focus, I would say that's the top focus of the whole hospital, is to really try to improve the value of care that we give to patients, try to improve the quality of care we give to patients, never rest on our laurels, always realizing that there's a way to be better, and trying to continue to push things forward. And so, for example, the way I like to think about it is, if you're one way to increase the value of care you get is by reducing the waste in our care delivery. And one of the biggest wastes that we can do as a hospital is waste your time, the patient's time. And that can be from either having to see too many doctors unnecessarily, having to go to different areas to get different things done. But if we can find a way, and we are doing this, to consolidate our care, make it more efficient for you, not waste your time, then you can spend more time with your family, you can spend more time doing the things you love. Especially some of our patients, unfortunately, they have cancers that are not good, and have a bad prognosis, and their time is very valuable, whatever time they have left.
Time is precious. And so is community support. And I know that GBMC is always open to having the community support in various ways.
That's true. So any kind of support we can get from our community, we welcome it. Any way to get involved, support your hospital.
On the website, there's plenty of ways to do that. Thank you so much. And also, before we let you go, you are a new dad, and we want to say congratulations.
Thank you. Thank you so much.
Dr. Farzad Masroor, thank you so much for joining us today in Ask the Oncology Expert, talking about thyroid cancer.
Thank you.